And he wanted to kind of do some stuff here to go over cardiac and start tying it in some more to the American Heart Association standards. I know that the lectures online still don't have all the new standards in them yet. I'm still waiting on the editors to come back. That's why Dr. Frame agreed to do this. Plus, there is another MD Roundtable link inside the MD Roundtable stuff on percomcourses.com that's about the new standards, specifically the new algorithms. So make sure you go there and listen to that as well. But this will help get us all up to date until those new lectures are done. That having been said, we are recording, so I'm going to turn this over to you, Dr.
Would you mute yourself?
I muted me and it muted you, I think. Let me try that again.
Well, if you can hear me, then I'm not muted. Testing one, two, three.
Yes, sir.
All right, you can hear me. So here we go. We're going to get started. Well, many apologies. Two sessions back to back with not only incredibly dangerous weather, but delayed in flights getting in and such. And well, as it turns out, we got a new computer for the occasion. So here we go. As Jane has nicely put to you, I have many years in the EMS field, as well as being a firefighter before I got into medicine. And I was a career firefighter. And what we're going to do today is a culmination of all those years. Now, just so you know, and just so you feel like you're not wasting your time, I write questions for the National Registry. And it's a committee of 20 that's throughout the country. And we get together and sometimes we pull questions out of the bad question bank, rephrase them, rework them, retest them. And sometimes we hit on the right questions right away. And subsequently for cycle 6, which is what the National Registry has been putting out, we have 1,000 new questions or old questions that we just keep recycling. We have 1,000 that live up in the cloud. And what happens is when you come in on your examination day, you sign in and it says, are you ready to start? You say yes. And here comes 150 random questions. And it's in 7 different areas. And subsequently, each area has to be passed individually. A fail in one section and a pass in the other 6 results in failure. So there are some sections such as cardiology, respiratory, airway management that are hit very heavily, maybe disproportionately so. But at the end of the day, as you keep answering questions, the computer kind of learns how well you're doing in a particular section, then starts giving you harder questions. The harder questions are worth more points than the softer questions. For instance, if it's a airway situation, they're going to say cyanosis represents, and then 4 answers. Hypoxemia would be the correct answer. So then you get that one correct. And then they move to an EtCO2 question. You scored 1 point for the first question, but if you get the EtCO2 question correct, such as what's the normal range, then you get that one. There's probably 2 points there. And then it moves to even a harder question because you got the first 2 right. And it'll say something like you have a patient with an EtCO2 of 60. What's your next appropriate step? Now we're getting into an airway management question, which is a little bit more difficult now. And you have to recognize that not only is 60 high, but it represents CO2 retention. And therefore I will bag the patient a little bit faster. And so you look for that correct choice. And obviously for answering 3 questions correctly, you've already scored 6 points. And that's the way an adaptive test works, such as this. Now, let's say you get the 3rd question wrong. Well, then it drops back to a question that's worth 2 points, a little softer question. And it's going to take you a little longer to get to the requisite 10 points for each section that you need to pass the examination. Now, it's all scaled. So 7 sections, 10 points does not equal 70. They're looking for a 70% or 75% pass on 150 questions. However, if it looks like you get a 75% correct for one section, it'll mark that section correct and it moves to another section. Here's the kind of the strategy behind the test is that we don't give you 10 airway management questions and say, oh, you did good, let's go to OB. It's not the way it works. All the questions are mixed and matched. The computer knows which ones are OB, CV, respiratory, EMS operations, etc. But it's not going to indicate that to you. You read the question and figure it out. And somewhere along the line, if you come up with 80, 85 questions that you answered that passes you, you may feel that, well, you got the last question correct, so I passed everything. Well, that's not necessarily true either. If you got the last question wrong, then that means that you failed. That's not necessarily true either because of this, you don't know where the points are at kind of thing. So it's a complex test, but computer figures it out pretty quick at a billion calculations a second. So it keeps pretty good track on everything. One of the sections that we have is on cardiology, medical, and part of that is cardiovascular emergencies. And we're going to go over 10 conditions over the next 3 lectures that you have to know for the examination. Now, I write the questions and I see the approved list of questions, but when you sign into that test, you get random questions. I have no clue what you're going to be asked. So we're going to have to cover all the pertinent points. So I took the 72 or 80 slide show behemoth that the National Registry puts out, and I kind of boiled it down to 2 to 3 conditions each session for the next 3 sessions, and I'm just hitting the highlights. So this is a target-rich environment. Every single slide has something on it that you're going to have to know for the registry. So I would encourage you to not only take good notes right now, but if there's something you don't understand, ask questions. This is the only time you're going to be able to ask without penalty. And more importantly, if you don't understand something or the whole lecture escaped you, or let's say you're one of those folks that are on a call right now and have to run out on a call, I encourage you then to come back and make sure that you find this lecture and go through it again. Because again, this is the largest section, which is cardiology. Cardiovascular emergencies is a part of cardiology. And subsequently, you're going to get the most questions on this. So here we go. What we did during COVID is took advantage of the fact that nobody went to work and they all stayed at home. And subsequently, somebody with too much time on their hands decided that we needed to revamp the EMS educational objectives nationally. So what you see in front of you here right now is pretty much what we've already been teaching, but we're going to put it a little bit more succinctly and organized in such a way that will help you study this for the National Registry exam. And again, I'm like Jane, I'm a realist, but I've been in the business long enough to know that even as a physician, you get through medical school any way that you can. And the real learning occurs when you're an intern, when you're a resident. And it's the same thing with paramedics. When I became a paramedic in the 70s, I learned all the book work. But when you get out in the field, that's where the real learning takes place. So your first day on the job is going to look a whole lot different than your 5th year on the job. And you're going to look back after 5 years of being a paramedic and you're going to say, geez, I don't know that I could pass a test anymore from paramedic school because I'm into reality-based medicine now. In other words, the real deal stuff. So in any event, just remember something, that you are studying for the day, not to test, but you're studying for the day that you're the only person standing between the patient and the grave. And so this isn't a matter about looking at the stuff until you get it right. You want to look at it enough so that when the question pops up, you can't get it wrong. And there's a big difference between those two philosophies. So let's start cardiovascular emergencies now. I'm going to go slow enough, but I'm not going to spend more than 45 minutes because we have 2 and possibly 3 more sessions. And I'd rather have more sessions with less intense material, or else I'll burn you out. So the first several that you see here right now goes from chest pain all the way to hypertensive emergencies. And each one of these has a different flavor to it, if you will. Chest pain, how do you handle unstable angina? Cardiac arrest, how you handle cardiac arrest. STEMIs, angina, and then non-STEMIs, the myocardial infarction that doesn't show anything on the EKG. Aortic dissections, which are particularly deadly. Pulmonary embolism, which are equally as deadly. Congestive heart failure and hypertensive emergencies. Now, not only are we going to be covering standard of care issues, but again, we're going to be covering the items that are going to be on this cycle of National Registry exams. If you plan to take the test within the next year, you're going to see this stuff. So let's start with this. The question that's going to be asked in the National Registry is, what's the leading cause of death in the United States? It's going to be a freebie question. It'll be a freebie question. It'll be heart disease, and no doubt about it. Heart disease is going to take this by storm. And there were 2.8 million deaths in the country in 2020. And of that 2.8 million, they broke it down into actual numbers. I gave it to you just as a list because they don't care about the actual numbers on the exam. They just want to know what's the most important. Heart disease is the #1 killer. 600,000 deaths last year, of which almost 250 to 300,000, almost half, never reached the emergency department. They died. Subsequently, it's still the leading cause of death, despite advances in cardiology, cardiac medicine, cardiac catheterization, stent placements, and bypass surgery. We're still losing a lot of people. And the reason we're losing a lot of people is because we found out that heart disease is not a single isolated disease. It's a culmination of hypertension and diabetes. So on the exam, what are the contributing causes of cardiac disease? And the answer, #1 is going to be hypertension. #2, diabetes. Now, we don't know why people become diabetics, and we don't know what causes hypertension, but we have medications to control them. Why patients die is because they don't control their own destinies. They don't control their own health. And so on the exam, you'll see what are one of the major causes of death. And it'll list a bunch of them. And one's going to be non-compliance, poorly compliant, people don't take care of themselves, words to that effect, that you'll say to yourself, my God, these people have killed themselves. Yeah, they have. They haven't taken care of the high blood pressure. They haven't taken care of their diabetes. We have high cholesterol, high lipids, which are the results of uncontrolled diabetes. And then we have hypertension, which tears into arteries, makes the heart work harder, and as a result, results in damage to the kidneys, to the heart, and to the brain itself. So let's talk about acute coronary syndrome. Let's talk about chest pain in general, but the acute coronary syndrome is, as Jane was talking about with troponins, the elevation of a troponin level is starting to come into play as part of the cardiac strategy, if you will, nationwide to try and reduce the number of deaths that are out there. So here's how it plays. Right now, you get an EKG on a patient, you respond to a patient, it's a 70-year-old male with a complaint of chest pain, shortness of breath, difficulty breathing. You get an EKG, oh, there's a STEMI. So you pack them up, you give them all their medications, including morphine and aspirin and such, and you go to a center or a hospital that has cardiac catheterizations. Now, we're taking that a step further now. We realize that over half the patients are coronary syndrome. In other words, you get the EKG and it shows non-specific changes, maybe flattened T waves, maybe flipped T waves, maybe ST segment depression, but the troponin comes back high. These patients are now going to be treated as a STEMI. And so even with no findings on the EKG, but with a troponin that's elevated, you're going to get you're going to have a STEMI here. And this is where we've been losing people. Some people will say, boy, I'm having chest pain. You get an EKG. Well, you're not having a heart attack. Oh, thank God. That's all I wanted to know. I'm not going to go to the hospital. Well, those are the people that usually wake up the next morning dead. They've had an acute coronary syndrome. In other words, a non-STEMI. Now, can a stressful situation cause enough change in the body's metabolic system to cause diabetes? The answer is no. However, if you do have diabetes, stress drives the sugar up. Now, there's a big distinguishing characteristics here, Tiffany, in that what causes diabetes and what causes you to be a diabetic in the first place, we haven't figured that out. Stress in a person who does not have diabetes will probably have a little bump in their blood sugar, but as long as the pancreas is putting out enough insulin, in other words, the islets of Langerhans are still producing insulin, and it doesn't matter how high your sugar gets. It will be taken care of by the insulin. We don't know what's causing destruction of the islets. Some people, it happens at a juvenile age, juvenile onset diabetes mellitus. In other words, insulin-dependent diabetes tends to be pretty treacherous. As you become adults, the insulin becomes, less capable of reducing the blood sugar because the cells have become more resistant to the insulin. Subsequently, the pancreas cannot kick it up a notch and produce more insulin. Subsequently, you get adult onset diabetes where you're producing some insulin, but you need medications to help keep the blood sugar under better control. And that's the differences between the two. Now, it becomes problematic when you get on the scene and you've got a patient that doesn't seem to be having any chest pain. They're just sitting there and they're telling you, I feel weak, malaise, fatigue. Their get up and go has got up and went without them. And that they just don't feel like they want to do anything. And over the past 2 or 3 weeks, and this is mostly true in women when they present, they'll give you the complaint that they're weak. Sometimes they're dizzy. Sometimes they have a near syncopal episode. And they've been having problems sleeping at night. Their appetite has been horrible, yet without eating as much, they're still gaining weight. These are all what they call constitutional symptoms that especially women who give you more atypical presentations than men do for cardiac disease. These are all trigger symptoms. And what you'll see on the National Registry is pretty much a question where you've got a 70 or 75-year-old woman who called the ambulance because she was having malaise, fatigue, near syncopal episode, a little bit of shortness of breath, difficulty sleeping at night. You run a 12-lead EKG and there's non-specific ST and T wave changes. So what's the next appropriate step? And the answer is going to be treat them like a cardiac patient, because these are all the symptoms that women have that leads to cardiac disease without having the chest pain, pale, diaphoretic pain down the left arm. half the women will get that, the other half won't get it. As in men, 75 to 80% of them are going to have chest pain, shortness of breath, pale, diaphoretic. But the other 20% are going to have malaise, fatigue. And here's a curious one. They get indigestion a lot. So you get somebody at 1 o'clock in the morning that, I got this real bad indigestion. There's a burning sitting right in the middle of my chest here. It doesn't seem to go into the neck, jaw, shoulder, arm, or back. But I'm getting this indigestion, and you're going to find that this person's probably a bit overweight. Said they took some Pepto-Bismol, maybe some omeprazole, maybe some Tums, whatever it is, and they're just not feeling right. So you run a 12 lead on them, and sure enough, there's the EKG changes. And it doesn't necessarily have to be ST segment elevation. If you've got anything like a flatten or a flip T wave in certain leads or ST segment depression, you could very well be running into an MI. Now, in the years to come, each and every one of you, both fire department as well as EMS agencies, are going to be carrying iStats. And those iStats are going to give you capability of measuring troponin. Just to review, troponin is the result of a substance released from the myocardial cells when those cells are being damaged by hypoxemia or anoxia. In other words, no blood flow to them. The artery's been blocked off, whereas about ready to get blocked off. All of a sudden you start seeing bump ups in troponin, and they'll bump up within 30, 45 minutes after the onset of pain. They come pretty quick. The beauty of troponin, it also clears pretty quickly, so I can track them in the emergency department. You bring me somebody in that's, let's say, has a troponin of 5 and non-specific changes on the EKG. I start nitroglycerin, heparin, metoprolol, aspirin, and start some IV fluids on them, get their blood pressure under control, and then I repeat it in 2 hours, and I can tell if I'm making any headway. So that's the future coming to you, and you're going to hear about troponin. Some of you may even have those on your rigs already, along with lactate and beta natriuretic peptide and all the other happy stuff that's out there. ABGs would be a good thing, Dakota. Yes, I think that ABGs would be a great thing. Right now we have ETCO2 and we got pulse oximetry close, and they're getting us closer. Pulse oximetry back in my day in the early 80s, we thought we died and went to heaven. Holy cow, now I can actually see if the patient's hypoxic, not try and guess until they turn into a Smurf. We couldn't figure out the way if these patients were hypoxic. So now we got a pulse oximetry, 85, 86, 88%, and we can see that. Well, then when they discovered that they could use ETCO2, end-tidal CO2, in the field as well, that gave us another respiratory parameter, but probably a more important one than pulse ox, because you go through 4 stages of respiratory insufficiency and respiratory failure, and it's stage 4 when you start seeing the hypoxemia. Stage 3, you run through elevated CO2. Stage 4, it's really elevated CO2, but you want to catch the stuff in 2, 3, where the CO2 is starting to creep up before you start seeing hypoxemia. So ETCO2 is huge. It's big. Blood gases are going to give us pH, as well as PO2, as well as PCO2. And it's going to give us a thing called base excess. And with the ABGs, you're going to get a hemoglobin hematocrit. And then you can make a decision, well, geez, ABGs don't look horrible, but they could be better. But, oh, by the way, their hemoglobin is half their blood volume's gone. In other words, 7. And that may be the result of chronic anemia. I mean, I think you can see here, without getting into that type of a lecture, I think you can see here that with the advent of iStats, and the iStats can do ABGs as well, when we start carrying iStats on the ambulances, it's going to give us so much more information that the paramedic of my day is going to be put to shame because of what you guys know. We didn't have any of that stuff. So a lot of times we just had to rely on our common sense and talking with online medical control and trying to get a good game plan for these patients. And oftentimes we couldn't really come up with what was wrong with them. Sometimes we could, sometimes we couldn't. So we missed a lot of diabetic ketoacidosis because we didn't have glucometers until the late 70s. And I think the iStat is going to be just more than glucose. It's going to be about 12 other parameters, and you guys are going to be able to treat a variety of problems that are out there. And if you're in a system that's kind of advanced and has community health paramedics, or at least follow up for patients that were hospitalized and discharged to home, you're going to be responsible for their ongoing care. It's all exciting stuff if you like that kind of stuff. If you don't like that kind of stuff, promote up real fast and get into something else, because paramedicine is really taking off big. Okay, so the third point here, it just happens to be suspiciously looking like one of the answers on the National Registry. Treatment with medications, of course, reduces ischemia or injury and such. We see that with nitroglycerin as well as metoprolol, aspirin, and heparin. But slapping an inch or two of nitro paste on a patient that's having active chest pain is a good thing. Yet when you guys get iStats and you start seeing troponins, or if you see changes on the EKG, the paramedic of the very near future is going to be hanging nitroglycerin drip, and then giving 5,000 heparin IV push. And now you've got half the drugs that you need started to get the patient to cath lab. The intent, something that we're just starting to pilot here in Texas, especially north part of Texas, is that if you're calling a STEMI or a non-STEMI from the field, because we got the iStats, then we bypass the ER and we take them right up to cath lab, the same way that you do on a stroke, where you come in and you go right to CT scan. Or better yet, when a pregnant woman comes in and she's having a whole lot of pain and she's crushing the stretcher and bending pipes and such because she's in labor, that patient goes directly up to OB. They don't stop in the ER unless they're getting ready, really crowning and getting ready to deliver. Those patients go right up to OB. Well, you're going to see them in the very near future with troponin and 12 and 15 leak EKGs. You're going to be bypassing the ER going up into cath lab. So this is part of the national strategy we're talking about. As we talk about national strategies, and as we talk about what is the most important factor in improving a patient's outcome, is having chest pain and shortness of breath, the answer is early 12-lead EKG identification, STEMI activation is the key step for the rapid patient access to a cardiac facility. But you didn't hear that from me. Okay. Now let's talk about stats again. Now, the key point here is the last one. And this is another answer on another question. Whether you get that question, I don't know. When it rains down from the cloud, I don't know which raindrop's going to hit you here. But if the question does have something along the lines of the greatest chances of survival result when the interval between the start of VF and defibrillation is as brief as possible, well, that goes back to way back when. I mean, you can convert 90 to 95% of the people if you defibrillate within the first minute, yet at the 6-minute mark, it starts dropping precipitously, so that by 8 minutes, your chances are 1 in 12,000 that you'll successfully resuscitate this patient. That's how important it is for bystander CPR. And more importantly, for patients, if they do collapse, that somebody go to the wall and grab the AED and put it on the patient's chest and see what happens. And it's all Good Samaritan stuff, so you're not going to be liable if you, in good faith, attempt to at least help the patient. Now, Every 37 seconds, somebody dies. Every 13 seconds, somebody starts experiencing chest pain, which is related to the heart. So that's a lot of patients. And as you know, you guys transport, for those who are on rigs already, you transport a lot of chest pain to the hospital. You're like, oh God, here we go. Another chest pain, another chest pain, another chest pain. Well, that's the statistic, but that's why heart disease is the #1 killer in this country. Now, the second point that I'm seeing there is for your edification. You can put your pencils down on this one, is that you should know that out of hospital arrest, 70% are at home. Public settings, airports, banks, restaurants, etc., where they have AEDs hanging on the wall, these are the most likely places that people do start suffering heart attacks and then cardiac arrest. And then, of course, nursing homes. So, but the third point here, the key is the key to the whole slide, and you'll probably see that on your exam. So let's talk about some risk factors for a moment. We have hypertension, diabetes, high cholesterol, high lipids, and a family history of heart disease. So let's start with hypertension. We don't know what causes it. We don't have a cure for it. All we can do is control it. And that's it. Subsequently, if a person's compliant with their medications and they can keep the blood pressure down, and here's a key number, copy this one down, stamp it on your forehead. If your blood pressure exceeds 140/85, you're considered to have high blood pressure. Okay. Now, diabetes is another strange animal. We don't know what causes it. We can't cure it, but we sure can try to keep it under control. Sugar and its attendant consequences, diabetes is not just about the sugar. It drives up cholesterol and it drives up lipids. Now, let's pretend that you and I are partners and we're both pathologists. And so we have a person who just passed away. Our job is to find out their cause of death. We open their chest, we get to the heart, we carefully and respectfully remove the heart, and then we start opening up the coronary arteries, 4 big ones. And lo and behold, there's plaque, in other words, cholesterol and lipid plaque stuck against the wall of the left anterior descending artery, which caused the cardiac arrest in this patient. Well, we take that plaque and we scrape it off and we put it under the microscope. We do some chemical tests on it. We're going to find out that the plaque is made of cholesterol and it's made of lipids. Now, consider this. That plaque continues to build up against the wall of all the arteries, going into the legs, going into the brain, kidneys, every place. If a person poorly controls their diet and don't take their diabetes and high blood pressure medications like they're supposed to, the plaque builds more and more. What happens on that last day of life for those people? That plaque gets to be 60, 70, 80% occluding of the artery. So you're only getting about a 20% flow. So they start doing some exertion where the heart's calling for more oxygen, and yet the blood cannot be delivered. So the blood pressure goes up. That higher blood pressure starts driving behind the plaque. Next thing you know, the plaque ruptures. You get 100% occlusion. Blood flow stops to the left ventricle, and the next thing you know, VFib. Hopefully the patient's just having chest pain, shortness of breath, difficulty breathing, diaphoresis, and you get on a scene and you start giving nitroglycerin, aspirin, and you stop the clotting of blood as it is occluding whatever is left of that plaque rupturing open and not letting blood through, or at least reducing the blood flow by 30, 40, 50%, whatever the plaque started out. But you and I are doing the autopsy here and figured out hey, the blood got behind the plaque because the blood pressure was too high. It peeled the plaque off the wall. And now the plaque is occluding the artery, and that's why the patient died of a heart attack. So you write down on the death certificate, cause of death, acute myocardial infarction, left anterior descending artery, as a consequence of, number one, hypertension, significantly contributed by, number two, diabetes, in addition to the following factors which have greatly contributed to the patient's demise. So I can pick you out two right away: smoking and obesity. Now, I'm not talking having a little tire around your waist. I'm talking about obesity, which is 25% over your BMI, not your target BMI, your upper limit BMI. So I'm sitting here at 6'2", 210. My perfect weight is 185, but my adjusted weight is 218. Well, that puts me in a BMI about 27. You look at some charts, they say, well, you're overweight. Okay, I'm overweight, but I'm not obese. Obesity comes in when you're over 20% of your upper limit. So I would have to be somewhere around 230, 235 to be considered obese, where that obesity will cause or greatly contribute to advancing my heart disease. Okay. So when we look at each other, when we look at our partners, when we look at patients who are having first-time chest pain or achiness or don't look like they feel right, we start getting into risk factors. And you ask your patients, do you have high blood pressure? Do you have diabetes? Do you take any medicines for cholesterol or lipids? Is there any family history before age 55 of somebody in your family who's had a heart attack? Unfortunately, with these risk factors, all we can do is diagnose them after they've occurred, and we try to treat them, which is why medical screening every year is real important. That's why as firefighters, if you're with a competent fire department, they send you for medical screening every year, not only for the cancers that are peculiar for firefighters, but also for cholesterol, lipids, high blood pressure, diabetes. Diabetes is a piece of cake. If you ever have a concern about that, do yourself a favor. Go to a store and pick up DEXA sticks or urine sticks that measure glucose. When you get up in the morning, your first voided urine is the one that you want to test, provided you haven't had an apple pie at 2 a.m. You should be able to dip your urine and decide, do I have something here that I need to be concerned about or not? The kidneys are pretty fussy. When your blood sugar gets over 180, it spills the sugar into the urine. Can't spill all of it, but you'll start seeing it leak into the urine. Below 180, it does not. If you're below 180, you're in pretty good shape. You can live with a 160. It's not so high where it's going to contribute to heart disease. But once you start getting sugars above 180, you start contributing to heart disease. But the beauty of it is that you can pick that up right away with just a urine dipstick. So every morning for 3 mornings straight, make sure you don't eat or drink anything after midnight. Wake up the next morning, first void into the cup, dip it, no sugar, cool. And you've done your screening for diabetes. Now, if it does light up with sugar, then obviously you visit your physician. And what we do is we do a little bit more sophisticated testing for diabetes that has to do with blood draws and such, and what they call hemoglobin A1Cs and all that happy stuff. The point of this slide is that the national register question is going to be: the following are risk factors for cardiovascular disease, except, and they're going to list cholesterol, lipids, diabetes, hypertension, and some weirdo disease process. Memorize that list that you see in the black on the left side of your screen, because I can assure you it's one of what they call mandatory question. In other words, no matter what test you're taking or what filters down from the cloud when you sign in for the test, a variation of these risk factors are going to appear in a question. They may ask it one way that says all of the following are, except. Another one's going to say which of the following is a risk factor for cardiac disease. And so you may see it in a different way, different flavor. But if you memorize the list and know that these are the risk factors, then you're in good shape to answer the question. Now, we get over to the right column. What are the things that the patient has or has not been doing over the past several days, weeks, months, or years? Physical inactivity. Well, you get one of those really obese people that are sitting on the couch. Well, I can't get up. Well, okay. Who brings you food? Nobody. Well, you made it over to the refrigerator, so something happened. I don't see an escalator in the house. So what happened? And the answer is they become so sedentary that they start developing a morbid obesity that's so profound that lipids and cholesterol become a big part of that. In addition to lipids and cholesterol, what happens? Diabetes gets into the arteries, hardens the arteries. That's what they call hardening of the arteries. Calcium jumps in with it, really stiffens up the arteries. And the next thing you know, you've got a person with all the risk factors. And then when they sit there and they say, I have chest pain and shortness of breath, well, getting the EKG, I don't care if it's normal or abnormal, they got heart disease. And like you saw in a couple slides ago, 20 to 25% of the EKGs that are taken out there are normal in the setting of acute coronary syndrome. In other words, the heart's getting damaged, just hasn't shown up on the EKG yet. EKG is beautiful when it shows you a STEMI, means nothing if it doesn't. The second is nutrition. I think that goes along pretty obviously with obesity and the other things that we talked about with lipids and cholesterol. Cut out this sugar, cut out corn syrup or any drink that has corn syrup in it. The soda it's a monster destroyer. You may say, well, I drink Diet Coke. Well, great, but it's still got corn syrup. And so even if you drink that corn syrup turns into marshmallow kind of looking stuff that sits around your waist. Subsequently, by cutting out corn syrup, cutting out the sodas, you just improved your chances of controlling your diabetes by, you ready for this one? 90%. That was an incredible stat that came out of the journal. The third is smoking and tobacco. That speaks for itself. Now, some people say, well, I smoke cigars. Well, do you inhale? Not really. Okay, so your only risk factor here isn't for so much heart disease as it is for cancer. Because the tobacco, just like chew or snuff, you put it in between your teeth and your cheek, and you're supposed to be getting the benefit of the nicotine. It's supposed to make you run around the bases faster or something. I don't know. Never figured it out. All I know is that when you come in for your dental appointment at age 60 and you've been chewing tobacco your whole life, and I get in there and I look at your mouth, because a lot of dental emergencies show up in the ER. And I look in your mouth and I see leukoplakia, in other words, little white spots, little pale spots all over the mouth and such. And okay. So we're going to start with a squamous cell carcinoma here pretty soon. So chew and snuff and cigars contribute more to oral cancers. Smoking not only contributes to bladder as well as lung cancer, but the nicotine stimulates the heart, and the tar and chemical substances in tobacco that you inhale gets into the lungs and stiffens the lungs. It loses their elasticity. Hopefully, you only get COPD out of it, and you get to wheel around a little oxygen bottle behind you for the rest of your life wearing 2 liters O2 nasal cannula. Pretty sexy, pretty cool looking, right? And yet the nicotine this whole time has been constricting the arteries of the heart to the point where they don't expand anymore. They don't become elastic anymore. So now you get stiffening and hardening of the arteries as well. And this is why I guess the bottom line here is if you see the question, it says, is smoking good for you? The answer is going to be no. It is one of the modifiable risk factors for cardiac disease. Overweight and obesity, we covered. High stress lifestyles and personalities. You get into a burnout situation with paramedics, with firefighters, police officers, doctors, and we burn out all over the place. Anytime that you're in a job situation where you don't really like the situation, or you have a lot of stress at work, or you're married to a type A personality, or maybe you are a type A personality, burning both ends of a candle, stress can contribute to worsening heart problems because it drives your blood pressure up. And if you are a diabetic, like we talked about earlier, stress can also increase blood sugar in your body by breaking down glycogen. Epinephrine or adrenaline is released from the adrenal glands, and it goes to the liver where glycogen is stored, and it cleaves the glycogen molecule, and part of it is what comes off is glucose. And so you can drive a person's glucose up just by being stressed all the time. Although I wouldn't, run to all your friends and neighbors and say, well, the reason why I'm obese is because I'm stressed. That has to do with bonds and some of the other things. All right, non-modifiable risk factors we talked about. In other words, things that you had bad genes about and you just got it. But going back to that slide 2 slides ago, you want to memorize the risk factors. Modifiable factors, we don't test on those, except for the smoking. But you should know that when you get on scene and you got that 70-year-old male sitting there who may be morbidly obese with cough, congestion, shortness of breath, chest pain, you ask about those risk factors and you ask about smoking. You're going to find that even though this may be their first presentation, you have to be on the alert for a cardiovascular emergency here. In other words, heart. All right, let me get to your questions here. We know that high blood sugar is considered diabetes, but is someone who has consistently blood sugar also considered diabetic? No, they are not. Diabetes has to do with the body's inability to reduce blood sugar through the production of insulin. Okay. Subsequently, when you overshoot and go the other way, that's not really a diabetic condition that we're concerned about. So Christian says, well, I've read a lot about excess sodium being a contributing factor, but no one seems to agree on a number. What is a safe daily maximum sodium intake level? That's a good question. The lower the sodium, the better. We know that salt, when it sits in the bloodstream, draws water in from your tissue. And so as a consequence, you got too much water in your cardiovascular system. When you combine that with the kidney's inability to regulate salt anymore because it's been damaged by high blood pressure, diabetes, now you got the basis for sodium being one of the contributing factors for high blood pressure. But as far as daily recommended value, it varies. It varies. I personally, we cut out all salt. There's enough salt on this earth in other foods and such without having to add salt that will give you enough sodium to make it through the day. And if your kidneys are in good shape, you regulate the sodium pretty good anyway. We tell patients that are hypertensive to cut out salt because we're trying to control what we can control. So you're in a high stress relationship with heart disease as a function of increased cortisol. That's correct. Effect of high fat, low carb diets on heart, bad news. You don't want to go high fat, all right? Bad. I like the low carb piece You want to keep the sugar under control because, again, just like salt, there's enough sugar on Earth in the foods that we eat and such where we can keep sugar up. And unless you're a diabetic, where we got to really watch diet, in other words, a diabetic diet, but high fat, yeah, we're looking at cholesterol and lipids here. You may say, well, I look at the back of the nutritional value thing and it says no cholesterol. That's very important. And the closer to zero that you can have with cholesterol, the better. Then you also look at the next category and say saturated fats versus unsaturated fats. And you look at that as well. I mean, I can look at these Planters peanuts, dry roasted peanut bottle that I'm looking at, and it tastes pretty good, but it tells me even though I don't have any saturated fats, or I'm sorry, I have 2 grams of saturated fats, but the total fat content's 14 grams. And then I look at cholesterol at 0 and I say, oh, that's cool. And then I got sodium here, which is 7%. So there goes the blood pressure. And then carbohydrates, 5 grams. Well, I don't mind a little carbohydrates every day, but I don't need 9%. Boy, if you ever pick up a Gatorade bottle and you look at it and there's 45 grams of sugar, I mean, these are the things that are hurting. Look, if you're a 25-year-old athlete in the NFL and you're working out every day and you have balanced diet with very strenuous exercise, okay, you can probably handle that sugar load. But if you're
Okay, thank you.
If you're mid 60s and mid 50s, if you're late 40s kind of thing, or if you're having a struggling with weight and such like that, well, you got to watch these carbs. These carbs are going to eat you up. Now, whether you have banana, orange, apple, and such like that, that's nature's own sugars. Body handles those a whole lot easier than Gatorade because that's not natural sugar in there. That's somebody playing with the body. Give you a complex sugar and rely on your intestines to break it down into 2 simple sugars. Well, sometimes the body doesn't show up to work every day. And subsequently, some of those sugars are going to get into the bloodstream. And next thing you know, we got all these other problems contributing to it. And then, of course, is that even with the new change in the textbook blood pressure? A textbook blood pressure is 110/60. 100 over 60, 90 over 50. Boy, I'll take all of those. But when you start creeping up over 135, 140, when you're starting to hit that range, we start adjusting your diet and then we start putting you on medication over systolic 140. So we break down hypertension in the stages. I'm not going to get into that with this lecture. Just know that it's a risk factor. All right, and I'm not going to do much with this slide because it's boring and there's nothing that came off the slide. Now, you get on the scene and you're going to say, okay, so why'd you call us today? Well, I'm having chest pain and shortness of breath. Okay. You get into your sample, get into the PQRST assessment. On the National Registry, we do not add urgency to a question just because the patient's crashing in the scenario. Take your time. Take the entire 2 minutes or more per question. You're given 3 hours for the exam. Take a minute or 2, preferably 2, and actually study the question. And know that you arrive on the scene of a 70-year-old male who's having chest pain, shortness of breath, difficulty to breathe, and all of a sudden he's starting to get altered mental status, blood pressure 60 systolic, and you notice on the 12-lead EKG that his heart rate is 180. What are you going to do next as the patient is starting to become syncopal and not breathing very well? What they're trying to do is get you caught up in the scenario. We want you to kind of choke a little bit. We want you to gag. We want you to feel like if you don't answer this question real quickly, the person in the question is going to die. Okay. Believe it or not, we can play on those emotions when we test people. It's not by intent, but we can see who is able to stand back and just take a deep breath and blow it out and relax and analyze the problem. And that's what you do on these questions. So you're going to get that question. You're going to have to go through, what am I picking out in the question here from a sample standpoint as well as a PQRST standpoint, and then decide. And here's the big one that we use on the National Registry exam. It's going to be an older female who's diabetic, hypertensive, and a prior history of heart failure. And you're going to have to figure out what the chest pain, shortness of breath, difficulty breathing is about. The next follow-up question may be, what are the significant risk factors this patient has that's causing or contributing to the above condition? Well, if you diagnose the above condition as something else other than heart, because you didn't recognize that the 180 heart rate and a 60 palpable pressure may have something to do with the heart, well, then you're going to get the second question wrong. So sometimes we bank these in threes. We'll give you the scenario and then 2 follow-on questions that relates to that. If you answer the first one correctly, and it's always going to be an older female diabetic, hypertensive, prior heart failure, then we're going to hit you with an EKG. And then we're going to give you an atrial fibrillation, RVR, whatever. And then we're going to ask you on the third question, more times than not, variable. Is it going to be a cardioversion? Is it going to be a medication administration? Is it going to be an MI where the medications may have to change? So you maybe see a atrial fib RVR, but you got ST segment elevations, or worse yet, you got ST segment depressions in 2-3 AVF V1 V2. And then you have to decide what's the next appropriate step. So I'm looking at the ST segment depression. Take note of this because this is one of the directions that we go on this question. If I see 2-3 AVF V1 V2 and they're all ST segment depression, maybe I should do a 15 lead EKG. Maybe I should do posterior leads. So your patient calls you for the chest pain, shortness of breath, diaphoresis, JVD, pain radiating in the neck, jaw, or shoulder as part of their chest pain, shortness of breath, and congestive heart failure. You do the MONA thing. You get the morphine, oxygen, nitroglycerin, and aspirin going. Beta blocker, if their systolic pressure is greater than 160, magic number. And whether you give them metoprolol PO or whether you give low pressure IV push or labetalol IV push, doesn't matter. Just know that the beta blocker is part of this whole thing when the systolic pressure is greater than 160. In this particular scenario, I gave you a 60 pressure with a 180 pulse. So beta blocker, probably not a good idea. Morphine, you can give 2 milligrams of morphine. It's not going to affect the blood pressure as long as A, you only give 2 milligrams, and B, you don't push it like you're caulking a window. You want to give it slowly over 1 to 2 minutes, or else you'll send this patient into a very bad hypotensive situation. And of course, don't forget your oxygen and nitroglycerin. So, high index of suspicion. Now, there's 2 major points that we test on the National Registry, and one of them is life-threatening arrhythmias. So you'll get a scenario like I just said, and we will be looking for a life-threatening arrhythmia, whether that's atrial fib RVR or whether, and you got to look at the EKG very carefully here, whether it's VTAC. Patient's got a pulse with VTAC, that's one treatment. Patient has no pulse, that's another treatment. And then, of course, STEMI. Now, we will give you 1 or 2 EKGs that are showing a STEMI. You have to identify the lead. That's the easy question. That's the 1-point question. Hey, you've got ST segment elevation in 2-3 AVF and leads 1 AVR, V5, and V6. So what do I got? I got an MI in the inferior lateral leads. So we look for geography. In other words, can you recognize on the EKG where the MI is at? The 2-point question may be, what would be the results of a patient who's got an inferior wall MI? What would be the next appropriate treatment if this is the vital signs? Or what may complicate this, such as Viagra, Cialis, and such? or what may, what was the third way that we phrased this on the exam? What would be the next appropriate medication to be given if you recognize that the patient has an inferior wall MI? And we may list IV fluids, nitroglycerin, aspirin, and something else that's not so brilliant. And subsequently, inferior and posterior walls tend to get IV fluids because of a reduction in preload. And all the other MIs tend to get nitroglycerin. Now, look at the blood pressure very carefully. We don't tend to fool new paramedic students with inferior posterior walls. We want them to realize that for the most part, you don't want to be giving them nitroglycerin unless, and this was a case I just had the other day, the patient's blood pressure is over 160. Now we got to get that blood pressure down below 160, and nitroglycerin could give us the advantage of not only dilating the coronary arteries, but driving the blood pressure down. Now, a person who's having a right-sided MI, in other words, an inferior or posterior wall MI, that has a systolic pressure of 180, you can drop a nitroglycerin under their tongue. It's not going to kill them. It's not going to take them from 180 over 110 down to 60 palp. That's not the way it works. I'm just saying that for inferior posterior walls, just realize that you could have a preload problem and you may be hypotensive and even bradycardic. Okay, so when we get into ST segment elevations, especially in the posterior leads, we find that when you do a simple 12-lead EKG, you don't necessarily pick up a posterior wall unless it's a really bad one. And you can see it, there's all kinds of EKG changes. It's rare to have an isolated posterior wall MI. 5% of the MIs are isolated posterior wall. They're usually associated with inferior walls. But you don't ever want to get into a situation where you miss an inferior or posterior wall MI. So we consider 15-lead EKGs. And I love it when a paramedic comes in and says, we didn't really know what was going on here, but we saw changes in V1, V2, so we went and slapped the 15-lead on them. And you can see on the diagram here that we put RV4 in the right lower chest and then V8, V9 at the tip of the scapula and then just medial to that. And that gives us the posterior leads. Now, the beauty of it is that when you look at the electrodes V1 through V6, and then the limb leads that go on the right shoulder and left shoulder, it sends electrical impulses down. But that impulse is skipping, for the most part, over the skin and picking up electrical activity as it comes off the heart. Yet when you put the leads on the posterior thorax at V8 and V9, now the electrical impulses actually get picked up through and through the heart. So you don't get a nonspecific ST and T wave change so much as you do, you pick up a posterior wall where all the leads look a little different because the path of the signal is different. In other words, it's not skipping across the anterior wall anymore. It's going through the heart into the posterior wall. And since the EKG is automatically switching what's positive and what's negative to pick up the various leads here, you'll find out that what looked to be a nonspecific EKG, when you do the 15 lead, you end up with this kind of EKG. And as you can tell, it's a posterior wall MI, but you also got ST segment elevation isolated in lead 1 and lead 2. Well, these aren't considered consecutive leads over here. You need ST segment elevation in 2 contiguous leads, 2-3 AVF for the inferior wall. And you may see some inferior wall changes, but the big player here is V1, V2, ST segments here, but the posterior wall 7, 8, and 9 are showing your true elevation. That's what makes this a posterior wall. And you get some inferior wall changes, but lead 2 isolated by itself without lead 3 and AVF doesn't necessarily make it an inferior wall. But since you're already seeing STEMI on the EKG, well, you already got your diagnosis. So now it's a matter of just getting the patient properly treated. So that pretty much sums up chest pain as it relates to MIs and such. So let me take a look at a number. Those are Tombstone 7, 8, 9, right? Absolutely, Tiffany. Yep, you nailed it. Chris, they let basics give nitro with no EKG. Yes. Yeah. What do you need to give nitroglycerin? I don't need an EKG. I need to know the blood pressure, because what's the contraindication for nitro? Blood pressure. Like I said, if you've got a 160, 170 blood pressure, I tell my EMTs who I authorize to do the big 8, the skills that are authorized by the National Registry, to teach the EMTs, if you think that they have a pretty good grasp on things and look like they're excited to be on the scene and actually serious about doing their job, well, then I let an EMT drop King Airways, give subcutaneous epinephrine, start an IV, give albuterol aerosols, deliver sublingual nitroglycerin. I think there's 1 or 2 other things in there I let them do, but the big thing is the King Airways, the start of the IVs, and the sublingual nitroglycerin. Do I need an EKG? No. If you're having chest pain and shortness of breath, even if the EKG is negative, I'm going to give you nitroglycerin, if anything, to try and diagnose the problem. So when I drop nitroglycerin sublingual, even in the emergency department while they're getting set up for the EKG, the first thing I'm going to ask them 30 seconds later is what? You getting any pain relief? If they're getting pain relief, then it's a pretty significant indicator that this is probably heart. Can nitroglycerin relieve esophageal pain? Absolutely. That's not for you to decide in the field. That's not for me to decide in the ER. You get them upstairs, get them admitted, let the cardiologist take a look at them and decide if they have to do stress treadmills, echocardiograms, maybe even cardiac catheterization. It's not an easy, well, you didn't have any relief with the nitroglycerin, so it can't possibly be the heart. Well, that's not true either. We gave the patient 2 nitroglycerins and he finally had some relief. All right, that's suspicious. I'll grant you that. That's suspicious. And that's what we're looking for. And if the patient's blood pressure is 180 and you give a sublingual nitro, that's fine, even without an EKG. If you got a blood pressure of 110, I teach the EMTs, start your IV, hang your 0.9 normal saline, and then you can try and give a sublingual nitro, because if they start to crash because of preload, what do? You give a bolus. You got to have the IV backup ready to go. But like this case I had the other day, inferior wall MI with a 200 blood pressure, man, I got the nitroglycerin started on the patient. We got him up to 30 mics before 30 micrograms per minute IV piggyback before we could get the inferior wall hypertension under control. So whoever tells you out there that you never give nitro in inferior posterior wall MI, if they're, well, let's just say I got some problems with that statement. It's not an entirely true statement. If they're taking PDE inhibitors, that's a good question. That's a pretty advanced question, Deanna. Again, if the blood pressure is above 160, then the PDE probably has not had much of an effect, and you could probably get away with a sublingual nitro. All I'm saying is be a little bit more liberal mindset when the systolic pressure is over 160. You may say, well, if I give the nitro and they've had a PDE, for those, that's Viagra and Cialis, the phosphodiesterase modifiers, if you will. If you give nitroglycerin in the presence of those medications, you could drop the blood pressure. That may be desirable when they're over 160. If they're sitting there at 180, oh, have you had Viagra? Yeah, I took it about an hour ago. Well, okay, we're going to start your IV, and then we're going to try some nitroglycerin and see what happens. So you start the IV, you give the nitroglycerin, they drop their pressure, you give them a bolus, they're fine. If you give them the nitroglycerin, they drop their pressure below 160, but they remain 120, 130, man, you've just improved their chances by a full 50%, because you've got to take that stress off that myocardial wall. And blood pressure elevation is not helping in the setting of chest pain. So, yeah, systolic less than 100, I wouldn't be too happy, about giving that. So then we got, isn't sugar subject to the person? Since we are different, a normal sugar to me can be high for someone else. That's exactly correct too. So we don't advocate treating blood sugars when they're below 180. You guys don't carry insulin out there. The only way that you have really to control sugar in the field is IV fluids. Now, when it comes to risk factors, if a person is on medications for diabetes, that's a risk factor, because not only do they go through that urine screening that I was suggesting for all of you, but once you've determined that you're spilling sugar, then you get into the office. They do the 3 mornings in a row blood test, fasting, to decide if you have diabetes. And that's usually defined by a fasting diet of 8 hours where the blood sugar exceeds 180. And then we give you a 3-gram oral glucose load, what they call a glucose challenge, and then test you 2 hours later. So I give you the glucose challenge, measure your blood sugar, poof. It's just like eating at a restaurant. It goes up to 250, 300, especially after the cheesecake. And then yet I should be able to take your blood sugar 2 to 3 hours later, and it should come down to normal. When that doesn't come down to normal, now I know that you got diabetes. So it's safe to say for you in the field that if they're on diabetic medications such as glipizide, glyburide, and all the other happy ides out there, not insulin, then you can be rest assured that they have type 2 diabetes. If a patient's on insulin, that should pretty much wrap it up there. All right, let me see the last 2 messages, and then we'll get into the. That stuff's horrible. Yeah, it is. It's like breast cancer. When a woman has mastectomy, a double mastectomy, I mean, this is what, and we're going to get into a serious conversation about the psychology of. When a woman has a mastectomy or a double mastectomy, well, that pretty much defines a woman. And when they lose the breasts, especially to cancer and such, not only are they faced with their own mortality of a very treacherous disease, but they've lost physical characteristics which define you, which make you women. And it's the same thing with men, although not as obvious. If a man psychologically cannot perform and they suffer from erectile dysfunction, this medication is given new life to some men. And once they are able to have sustainable erections and become intimate once again with their partners, this too defines a man. And subsequently, when they're 18 to 30 years of age, usually not a problem. But when you start sneaking up into the 50s, 60s, 70s, now we got problems. Subsequently, if you can just push the sun back into the sky for another 5 or 10 years by taking Viagra or Cialis, that's what defines a man. And when you talk about stress levels in patients, or when you talk about moods and mood swings, depression, especially depression in the elderly, patients that are over 75 are considered elderly, although there's some people in their 50s who are in such poor disease shape that they too can be considered elderly from a physical condition standpoint. But when you get into the elderly where it's not possible to perform anymore, it's not possible to look hot anymore to whatever gender you're trying to appeal to, depression can be deadly, stressful, and it's deadly. And so is this stuff horrible? It is if we have to treat a patient that's having a heart attack and the medication treated or started that, and then the complications that come as a result of having a heart attack while you're on Viagra or Cialis. But is it really horrible? And what has it done for the greater number of people out there? And what has it done for relationships to persons who have had a healthy sexual lifestyle their whole life, and then all of a sudden lose that? And yet the Viagra and Cialis brings it back. Or what has plastic surgery done for women to repair and replace diseased breast tissue so that they look again attractive as to what defines a woman from a physical characteristic standpoint? You can't discount what goes on with a person emotionally. So anyway, that's the reason why we have this. I feel like they can figure out a way to make something that doesn't have all those potential complications for people who need them. Yeah. Lactated over NS, that's a debate that's been going on for a long time. I'm not a big fan of lactated ringers, especially in trauma, because you're introducing an acid into a trauma situation, which is already acidotic. When they become hypotensive, blood loss, etc. But the beauty of NS and LR, it stays in the bloodstream. And so you can count on it being a volume expander for 15, 20, 30 minutes, sometimes an hour. And maybe the 15, 30 or 1 hour time that buys them temporary increases in mean arterial pressures that can sustain a person until we can get blood into them. Now, sooner or later, all the MS systems will be carrying whole blood. We still haven't figured out a way to make blood, so we don't have a good substitute for blood in the field, which is why we don't give anything in the field. But you're seeing helicopters carrying it. Now you're seeing some EMS agencies that have a good relationship with their local hospitals. You're seeing some EMS agencies actually carrying whole blood. And I think you're going to see that this is going to be a trend in trauma management as well. Oh, the glucose drink was horrible. Yeah, they are. And you know, once you cut out soda, you cheat 3 or 4 weeks later and you say, I'm going to just have a can. And then you drink a can. You're like, oh my God, I'm eating a spoonful of sugar and it ain't Mary Poppins. Okay. I'll tell you what, let's break it off here. I'm not going to start CHF. We already covered cardiac arrest, chest pain, STEMI, non-STEMI, posterior 12-lead EKGs. But what I did is I gave it to you focused from the standpoint of not only what you expect practically with your patients, but also to pinpoint where the exam is going to be focused. It's going to be focused on risk factors and 15-lead identification of inferior posterior walls. And of course, some of the points that I gave to you earlier to pay attention to on the exam. So does anybody have any final questions before we wrap this up?
Wow, this was a good and very vocal group tonight.
Yeah, that's certainly one of the better ones.
So we have MD Roundtable tomorrow night with Dr. Phillips. Wait a minute, somebody just popped up with a couple of messages here, maybe. Okay. There was a couple of more questions there for you, Dr. Phillips, Dr.
Yeah.
Frame, sorry.
Yeah, I was looking at Chris Snyder's why metoprolol as opposed to some other beta blockers. Metoprolol tartrate is fast acting. It's like a Atenolol. It'll work within 5, maybe 10 minutes. It's pretty darn quick. And if you give metoprolol IV, which is low pressure, it works within seconds. Also, metoprolol is considered a selective beta 2 blocker. So let's look at beta 1 for a second. You stimulate beta 1, what do you got? You got a faster heart rate. And if you stimulate beta 2, you can constrict. I'm sorry, if you blockade the beta 2, you can cause bronchoconstriction, which is why we didn't give the old beta blockers in the asthmatics. Well, when we talk about selective beta blockers, we're talking about no beta 2, all beta 1. And beta 1 either stimulates the heart or it doesn't stimulate the heart. So if you have a fast heart rate, I give you a beta blocker, it slows it down, but that blockade does not simultaneously cause bronchoconstriction. So now metoprolol is safe to use in asthma. Absolute contraindications to the old beta blockers was asthma, COPD, and of course, second, third degree heart blocks, congestive heart failure, et cetera, et cetera. Well, now with the selective beta blockers, the beta 1, we can kind of fine tune that. We can give it in diabetics, CHF. The objective being, let's just get the blood pressure down. I hope that answers your question. Is there an age group it mostly affects in women? I'll assume, Maria, that we're going back to the discussion of atypical symptoms because women don't necessarily show chest pain. And the answer is any diabetic woman, because they get diabetic neuropathy, and any woman really over the age of 55 that has these constitutional symptoms should be suspicious. Now, 55 is not an absolute break-off, but you're going to find over 90% of the patients are over 55 that have these constitutional symptoms. New ambulance causes interference on our pulse ox waveforms. Good question. There's lots of possibilities there, and I don't know that I'm qualified to answer that from an electrical standpoint. Medicine is definitely revolving. You have no idea. My paramedics were hanging nitro drips in 2001, 2002. Yeah, we were hanging nitroglycerin in 1978. When I became a paramedic in 77, of course, paramedic courses back then were 4.5 months long, 3 times a week. Now we don't know 10% what you guys know now. Back then it was just, here's how you function. This is the EKGs you need to know. Here's the 20,000 drugs you need to know. But you're going to call online medical control for everything anyway, so don't get too cocky. Now it's all protocol driven. We lay on the professional and independent judgment of the paramedics in the field, and they call online medical control only if they really, really need to, where it's not covered by protocol. But you guys have so much more base knowledge than we did that if I took you right now and took you back in time, you could probably function as an intern. Emergency medicine has just come such a long way, but emergency medicine developed because they put paramedics out on the street. Remember Johnny Gage, Roy DeSoto out in California, and the paramedics are coming in with patients into hospitals, and the doctors are going, well, what'd you do that for? And the answer is, come on, doc. So emergency medicine came about as a result and started developing physicians to keep up with the paramedics, if anything else. So, yeah, it's a revolving door, all right. Bleeding concern with heparin? Absolutely. It's blood thinner. It's one of the most potent blood thinners that are out there. It's a good question, Chris, from the standpoint that if I gave heparin in the setting of a person who's having bleeding someplace else, it's not going to help. It's going to hurt. It's going to hurt real bad. But heparin in the setting of a person who doesn't have contraindications, such as actively bleeding, heparin is great because it just pretty much stops platelet activity, stops any clotting through what they call the extrinsic pathway of the coagulation cascade. But it stops the blood from clotting. So that little area that's left, that blood is sneaking through past that big old occlusion in the left anterior descending artery. Well, at least I know I can get 1% of the blood through. And that may be enough to stop infarction. It's sure as hell given a lot of ischemia and it's given the patient a lot of pain, but I just need to buy some time until I can get them the cath lab. Heparin helps me do that. Yeah, it's a potent med. Yeah, it's got contraindications, but that's why we train you guys 12, 18 months. That's why we train you intensely. We give you dangerous drugs and say, okay, only use it in these situations. And here's the training to recognize those situations. And here's the training to say you should avoid it in these situations. That's the trust that we have as physicians for paramedics. It's an incredible trust that I have, especially with PERCOM, because we have a little bit longer program, but you'll find, as opposed to college programs, that we have a more intense program. And of course, we rely a lot on you guys having independent capabilities to self-start. So we count on that motivation that you guys will learn a little more. That's why we give you more, so that you can function competently in making these very important decisions. Heparin will be a part of that. And let's see, what else we got? Am I missing any more questions, or?
I think you caught them all.
If I missed anybody's question, can you repeat it for me real quick?
You can also unmute your microphone and talk rather than typing if you want to.
So metoprolol, once again, there's two types. There's a succinate and there's a tartarate. The succinate is something that we give to patients at home because they'll take it once every 12 hours, and it tends to be a little longer acting. Unfortunately, it tends to take a little longer to act. Now, tartarate, metoprolol, is a selective beta-1 blocker. Back in the day, Inderal, Tenolol, some of the other medications, if you blocked beta-1, you slowed down the heart. Unfortunately, you blocked beta-2, which caused bronchoconstriction. So even though you got a benefit in one area, you hurt the patient in the other. Well, if they had normal lungs, then you really didn't see much harm. But you did see it if the patient was asthmatic, COPD, congestive heart failure, or even diabetic, because where else are beta cells in the body? The pancreas. And so if you block them down, then you set up for a blood sugar that got real, real high. So when they invented metoprolol, discovered metoprolol, they noticed that it was a selective beta blocker. In other words, it was not a broad, non-selective beta blocker to block both beta-1 and beta-2. We selected beta-1 to leave beta-2 alone. We don't want to mess with the lungs. Beta-1 selective beta blocker is metoprolol. It'll slow down the heart and take the blood pressure down without ever affecting the lungs. So as before, with the old beta blockers, we couldn't give it to asthmatics, CHF, or COPD diabetics. Now we can, because we're only dealing with beta-1. That's why we chose metoprolol.
Well, I think everybody's probably brain dead at this point. It was wonderful. Lots of good information. Dr. Frame, do you know when you might be wanting to do the part 2 of this?
I'm going to leave that to your class. If they can come up with a consensus on when they want it, Let me look at my schedule real quick. Why don't you guys plan for something next week? I want to hit these 3 or 4 lectures pretty hard back to back to back, so we're not dragging out CV emergencies the whole. Yeah, I agree with Tiffany.
I do have Dr. Troutman next Tuesday already going to be doing I don't know what he's going to be doing, but he's already on for next Tuesday, which is the 18th.
Well, Dr. Troutman is one of the premier EMS directors in the state of Texas. He has a very impressive credentials, but he's also well regarded in the Lubbock area, where he pretty much runs the whole Lubbock, Amarillo areas there. And quite an extraordinary fellow, and I think you'll enjoy his lectures quite a bit. From my standpoint, I want to get something as soon as possible.
Well, Snyder suggests next Thursday
That'd be fine.
or Monday.
That'd be fine too.
Okay, so we got Thursday and Monday. Which one?
Well, what I'll do is I'll shoot you an email as soon as I get unpacked, because we ran right over here from the airport. I'll shoot you an email, give you potential dates, and if you wouldn't mind putting it out to this group of folks, and you guys decide when you want it. If you want it both days, we can.
So it looks like the majority of them are voting for Thursday.
Let me look at something real quick.
That would be the 20th.
20th. Thursday.
We do have that's the also day you have a paramedic grad exam that morning. So
Yeah, but it's important I give these guys rapid fire CV emergencies, or else they're going to be spread out all over the curriculum, and I want to hit it while the iron's hot right now, so they can integrate from one to the next to the next.
well, I got you. It looks like most of this group says they can be available Thursday, but a lot of them can't do Monday.
So you said the 20th?
Mm-hmm. That would be next Thursday.
Oh,
I would assume,
perfect.
because we've already got him MD round. Is that good?
Yeah.
All right. Well, let me put that on the calendar here. MD roundtable with Dr. Frame, 8 p.m. Okay, we can do that. Next Thursday, the 20th. So we've got roundtable tomorrow night with Dr. Phillips, roundtable on Tuesday with Dr. Troutman, and roundtable next Thursday for part 2 with Dr. Frame. I think that works.
Yep.
All right.
Well,
Thank you. Thank you, everybody. I hope you enjoyed the lecture.
Jane, make sure you send me an invitation.
I will do it. Absolutely.
All right, guys. Thanks for everything. Thanks for the great questions, too. That was very good.
All right. Good night, everybody.